Good afternoon. I'm pleased to welcome all participants to this side event on improving prevention, prioritizing effective approaches, and secondary prevention. My name is Eliza Kurcevič, and I'm a senior program officer at the Eurasian Harm Reduction Association. And thank you for joining us once again. And in the beginning, I would like to inform you that our side event is being recorded and also live streamed on Facebook. In case you will have any questions, and questions are very welcome, please use questions and answers section. Please use that function, which is like below your screen. And in the end of the webinar, we will have some time to go through these questions and answers and your input, and to ask our panelists the main questions which you will ask. As well, we encourage you to interact in the chat. So please be respectful to each other and treat everyone equally. As well, we would like to ask you to introduce yourself, like your name, from which organization and country you are, and you can do it in the chat function as well. So before starting our event, I would like to give a few simple definitions, which will be very relevant to our side event. So let's start with the primary prevention. So primary prevention promotes the non-use of drugs and is aimed basically at preventing or delaying the first use of drugs and the transition to more serious use of drugs among occasional users. And also we will use a term of definition of secondary prevention. So secondary prevention programs target those individuals who are already using some substances. And at the CND, this is referred also to as initiatives and measures aimed at minimizing the adverse public health and social consequences of drug use. So I'm happy to open the side event, and I would like to give a word to Irena Molnar, who is graduated in ethnology and anthropology, interested in social aspects of substance use that led her professional career development to engagement in drug policy on a national scale, but as well internationally. She's an active advocate for sustainability of harm reduction programs, also devoted educator and mentor, researcher focusing on new ways of education and sensibilization of society regarding psychoactive substances and substance use. Irena is also a co-founder of the NGO Regeneration. It's a youth-led NGO from Serbia, where she's elected there as an executive directress. And she's also YADA Foundation Council member and a steering committee member at the Eurasian Harm Reduction Association. So today, Irena will present to us assessment on drug education conducted in Bulgaria, Hungary, Lithuania, Poland, and Serbia. Irena, you're very much welcome, and please share with us the results of the assessment.
Thank you, Lisa. Hi all, and thank you everybody for joining us today. As Eliza explained, today I will present the results of the research we done last June and July throughout the project. Let's talk about drugs, new ways of communication methods with youth. The project itself is a consortium of 6 organizations and networks throughout Europe. And before I start, I would like to bring you a little bit of voices of youth workers from our organizations who, for this particular event, recorded 2 videos for us. One is their opinion about drug education at the moment that I'm going to play for you now. And I'm saying sorry in front, maybe the sound and the picture won't mix at the beginning. It's the technical reasons playing throughout the Zoom. And after I will record you how they see effective drug education. So I'm going to share you the first video.
Drug education in my country is just neglected.
And not holistic.
Judgmental and stigmatized.
Restrictive.
Scarring.
Belief-based.
Scornful.
A very poor level.
Absent.
Based on stereotypes.
Boring.
Destructive to life.
Inaccurate.
Deterrent.
Condemning.
Quid.
Frontal.
Generalizing.
Inadequate.
Ineffective.
Insufficient.
Lacks partnership.
Not existing.
Not informative.
Stigmatizing.
Not practical.
Outdated. Not complete.
Non-existing.
Stigmatizing.
Threatening.
Underdeveloped.
Underfunded.
Unreliable.
Absolutely lackluster.
Okay, so that was the message our youth workers had to wanted to give you before we start, and this is the presentation. So basically, the Let's Talk About Drugs project is a consortium led by a consortium made 2 years ago, and I believe that exactly happened at CND. So this is the project co-funded by Erasmus Plus program of European Union, and within the project, our aim was to develop new ways of communication in regard to drug education with young people that should be given by our youth workers in the first place. So what we believed in the project was particularly important was that we wish to do the research before we even start thinking about ways of communicating with young people, since we are all definite about rapid changes on the drug markets, rapid changes in the behaviors, specifically regarding young people. So we wanted to hear their opinion about effectiveness and the way they have been taught when drugs are in question and other psychoactive substances. So the partners on a project, project is led by Eurasian Harm Reduction Association, and the partners on a project are Smart Foundation from Bulgaria, Yoda from Poland, Rights Reporter Foundation from Hungary as well, Young Wave from Lithuania, and Regeneration from Serbia. And Vacu Association from Hungary as well. So most of these organizations are, except of the Eurasian Harm Reduction Association, Rights Reporter Foundation, who are running this project basically, are youth-led organizations working on the ground with young people who are using drugs. So we value their opinion in the assessment based on which we are going to create our future activities and manual on drug education. So methodology that is used in this project, it's set it up to be completed as in several parts. So to achieve the goal that we wanted, we firstly did the desk review. That means that the organizations assess the policy analysis and researches and strategies and action plans within their own countries, after which we did the qualitative assessment of existing drug education practices and their perceived effectiveness. So we actually asked young people how they think this is effective, what they have been given, and the quantitative assessment of youth experiences with drug education and its effectiveness through the analysis of their knowledge and opinions about drugs and drug use. So we kind of went into survey questioning, but we also sat down and did the focus groups with youth workers that are actually working with young people in different settings. So we also did set up the focus groups to be different depending on who we are talking to. So we had the focus groups and semi-structured interviews with young people who are social workers, educators, who are not actually working in a field of prevention, harm reduction, or drug education, but are working with young people to see how often they come across drug topics in their work. So then we had focus groups and semi-structured interviews with youth workers who are peer-to-peer educators, specialists who are working in the field of prevention, harm reduction, drug education, and also assess the opinions of young people who came across these services, because it's not common in each of the country, the services and the structure of how services are offered are not totally the same. And then we had the focus groups and semi-structured interviews done with the young people who were willing to share their opinions and knowledge about drug education in the country. So we also additionally did interviews with the national experts on drug education, that meaning that all 5 countries, organizations picked people who were from the government bodies usually, and who are setting up the prevention programs in their countries. So that being said, we did that in order to have the complete picture of how this is set up. So difficulty in this research was that it was set up in 5 different countries, and countries are different in a variety of things, but also like population. Between Poland and Serbia, there is a huge difference. And what else was an issue in data collection was that it was done in the middle of the pandemic. So we needed more time than we originally thought we will need. And also it was a little bit difficult to implement the focus groups in terms of doing it online. So the only difference among some countries is that some organizations could do it in person, but some of them could do it only online. So ethics and confidentiality, we took also very important in this research, and we managed to have ethics committee approval in Hungary and Serbia. So to continue with the crunching the numbers for you. Lifetime prevalence of drug use of illicit substances is, as you see, most of the people had experiences with drugs sometimes in their life. And you can see that the most common method of drug administration young people reported was smoking, followed by oral administration and snorting. That also has to do with the type of drug that they use. So smoking, as cannabis is one of the most used substance, smoking is naturally the most common method of administration. But what is common for all countries is that everybody reported that it's fairly easy to find illegal substance in their country. So 91% people in Poland said exactly that. 81% in Bulgaria, 78% in Serbia, 73% in Lithuania, and 72% in Hungary, which is something that we thought it is important to emphasize. Settings where study participants received drug education is, as you can see. So we asked them questions about educational classes on drugs that they had in school setting or university setting, and we also asked them questions about non-formal settings where they could receive the education related to drugs. So you can see that in Bulgaria, 53%, in Lithuania, 51%, in Poland, 40%, in Hungary, 23%, and in Serbia, 15% of respondents reported that they had never received any form of drug education, which by this point in this time frame of the project was something quite important for us, because based on what they are going to know if something was effective or not, the idea that they did not receive any form of drug education even through their formal school is something that is also quite important in perceiving how we are going to plan further activities. In regard to who provided the education for young people, we can see that in most of the cases, is actually in Poland and in Hungary, and these are police officers, which you will see later. Young people do not really like, and they cannot be trustful in that environment, which they believe it's important when we are talking about drug education. So most of the lectures giving in formal settings are given and provided as one-off formal lecture, which doesn't really tackle, we believe it doesn't really tackle the idea of being educated on drugs in an effective manner. Later on, we asked them who provided the drug education in informal settings. And as you can see, it is the biggest difference, where in most of the countries, youth workers were the ones delivering the education programs to young people when out of school or university. So the most common places where respondents received that drug education are festivals and parties, youth organizations, harm reduction organizations, exactly settings which are not school and university, and actually prevention that is not primary or universal. What were the informations, and what were the informations they are giving to young people in formal settings? Are, as you can see, the most common is information about the effects and risk of the substances, and one of the least giving information is, for example, information about drug overdoses and overdose prevention, information about available health and social support services, including harm reduction services. So what was taken out of this question in comparison to the countries is that in Poland, for example, 61% says that they did not learn a lot from these sessions. 51% people disagreed with the statement that the education was provided in a non-judgmental way. And judgmental way of education is something that is most commonly mentioned in the focus groups as well. And 47% stated that could not honestly share their experience. When we're talking about the experience, most of the young people in focus groups wished they can discuss things that they have in mind, but just because they do not feel safe in the environment the education is giving to them, they are choosing not to share. So in most of the countries, we could see the similar trends. So
Irena,
in
could
other
you please
settings,
step up?
yes, so this is my last slide. So in other settings, just what I said before, education received outside of the schools was evaluated more positively. So it was assessed that being less judgmental, participants thought they received more new, honest, and useful information that during the education delivered at schools and universities. So I will end here and I will play you the video as well. So what we came with after this research that lasted almost 3 months is that young people opinions about the drug education should be provided by a person who has received special training on substance use and has firsthand experience of substance use. It should be delivered in a non-judgmental way based on scientific evidence in an interactive manner using engaging modern tools and platforms, preferably in a small group, so not in a class where it's usually delivered, and in the format of an open and honest dialogue. So that being said, I will leave you with the messages that young people had for you. So just a second. Here you go, enjoy.
Accessible.
Informative. Adapted to human, not drugs.
Appreciated.
Based on facts.
Bottom up.
Science-based.
Available.
Effective.
For everyone.
Free from prejudice.
Global. Honest.
Empathetic.
Inclusive for the vulnerable groups, without stigma, and community-based.
Playful.
Interactive and relevant.
Interesting and useful.
Science-based.
Making people aware.
Modern.
Science-based. Open.
Objective.
Open-minded.
Personal.
Progressive and not based on the fear.
Psychological therapy based.
Realistic. Based on science.
Technical.
Thought-provoking.
Tolerant.
And interactive.
Up to date.
Science-based. Useful.
And knowledgeable.
Okay, thank you.
Thank you so much, Irena, for your presentation, and thank you so much for all the voices of young people which you brought here to our side event. And let's go to the second panelist. Ben Bergsang is the Deputy Executive Director, Programs for the New Zealand Drug Foundation. Ben and his team lead projects that bring different sectors together to improve well-being and reduce harm from alcohol and other drugs. He has extensive experience establishing and managing school-based, community, and residential drug and alcohol programs. In addition, he's the chair of the professional association that oversees the competence and ethics of the addiction workforce in New Zealand. Ben will present the Tūturu program in the New Zealand for teachers and educators to implement a whole school approach to reduce drug and alcohol-related harm in the secondary schools. Ben, the floor is yours.
Fantastic. Good evening, everyone from New Zealand. So what I'll cover today, we're talking about a program that aims to prepare all students for a world where alcohol and other drugs exist. The reason why all is in italics is that we know that every young person will make a decision about whether they use substances. Some of them, or many of them, will try it. Some will use it and experience short-term harms, and a few of them will try it and develop long-term problems. And we want to make sure that all of those students get both the education, the support, and the community that they need at school to be able to live healthy and successful lives. What I'm going to focus on in this snapshot is what we learned about from this project around a systems approach to prevention. So we know, probably similar to many countries overseas, that where we've come from is not talking about alcohol and other drugs at all, sometimes only sharing the message that if drugs and alcohol are spoken about, that drugs cause extreme and terrifying harm. We know from a lot of research that this is effective for people who are probably not going to try it anyway, but really ineffective at reaching young people whose life context and life experiences tell them something different. They'll just disregard that information as being untrue or uncredible. Where a lot of what we're finding in New Zealand, where a lot of our schools are at, are over preparing students for the risks that a few will face, while spectacularly under preparing them for the decision that all of them will make. And often health topics competing with each other for which is the most risky. And also teaching about alcohol and other drugs primarily through behavior management after an incident. Where we're moving to is helping students progressively build the knowledge, values, and competencies that they need. And because we're used to talking about alcohol and other drugs as a set topic, we feel like this requires a learning progression for alcohol and other drugs as a topic across all schooling years. And what we know is that many of those competencies, when we drill them down, are well-being competencies that go across any health topic, and that ultimately we're trying to build core health knowledge, values, and competencies, particularly critical thinking, so that all students are prepared to live in a modern world, and we don't live our life segregated into different health topics. Context-wise, this is where we're mostly at within New Zealand along that spectrum. What we are trying to do here in this approach is help health providers and schools work together to reduce their alcohol and other drug-related harm, particularly in ways that improve student engagement with school as a key protective factor, their critical thinking, and ultimately their well-being. As a little bit of context, in New Zealand, our schools have a huge amount of flexibility to adjust their learning and what they teach in the curriculum and the disciplinary processes to reflect their communities and student learning needs. So it's very divested out into the communities and very adaptable to the communities. I won't spend too long on this because I want to get to some of our learnings, but we did have an independent evaluation across the whole time that we were doing this project and found that the review and planning at a local level, the resources that we created for that, and our implementation resources helped to change the focus from being punitive and using sanctions to punish students through to pastoral support, where we support students and help them to learn the skills that they need to live healthy and successful lives. What we are aiming to do is create this ecosystem of learning and support that helps students learn and develop. And you'll see there that inverted triangle that I was talking about earlier, where all students are making those decisions, and there's those few students at the bottom, where most of our partnership between health providers and schools fit is that health providers commonly partner with schools at the bottom of that triangle to work with a few students and provide them support. And this is trying to adjust that level so that it's schools and health providers working in partnership at the top of the triangle, where they can support all students to learn what they need and make sure that it's aligned all through. What this means in practice is that a suite of interventions need to be developed that align what students experience in the school environment that helps them to develop, what they learn in the classroom, how they're supported at school when issues arise, how professional services provide additional support, and how the wider community of school, their families and services help them to lead these healthy and successful lives. And we found that there is a lot of solutions that need to be created together, because the gap between education services that commonly are at the top of that and treatment services that are commonly at the bottom is very, very big. Ultimately, we were learning that setting up the team or the leadership team within schools is really important, because this innovation takes at least 7 years to be able to make school-wide changes in our secondary schools. And it feels really overwhelming for schools. So we're trying to map out a process where they could have a team where they set the vision. They may choose 1 or 2 meaningful actions a year that can keep them progressing towards that ultimate vision of a healthy and well school. And some of, on that right-hand side there, is the elements that they could pick and choose from to align with the communities that the priorities of their school or of their community. What we found was really important is to connect all of this together, because disconnected initiatives disrupt how other approaches work. And what I'm meaning by that, for example, if we go back to that triangle again, we know that if people believe that drugs are bad and people only need to know that extreme and terrifying harm and all of the extreme harms that they could experience, that could still work really well for the primary prevention that sits at the top and the treatment services down the bottom. But what some of that does is creates a blind spot where secondary and tertiary prevention in the middle becomes less available and less effective. And in fact, that education around the extreme harms that students who are already starting to use tend to disregard can further stigmatize them from accessing support, making it their problems larger before we can support them. One quote from the principals is, it takes time for students to connect what they learn with their lives. And we found this really strongly, that it didn't really matter what was being taught in the classroom if it wasn't going to be role modeled throughout the rest of the school community. So if they were learning about how to seek support in the classroom and about harm reduction and about the facts and effects and stuff like that, if the rest of the school community was dealing with it through sanctions, punishment, or turning a blind eye to it, then it was less able for those students to connect those skills and put them into practice in real life. So that's why all of this connection and alignment was really important, because dropping in initiatives into the middle won't work. We found that we know that people learn through progressive exposure to new ideas or skills, and that we've found that we perpetuate inequity in these health outcomes if we're using learning approaches that only transfer knowledge or don't adjust to the learning needs and experiences of students. I'll give you a little bit of context in New Zealand around this. We have in our health learning area of the New Zealand curriculum, there's a whole aspect around critical thinking that gives people the skills and knowledge to be able to make good decisions, to communicate with others, to know what's important to them. 2/3 of our year 8, which sits around about 12 years of age, 2/3 of them are below the expected level of critical thinking. So if we only did a manualized program that had experts going in and delivering in secondary school, they're less able to translate and adjust that learning, that teaching to the learning needs of their students. And so it might be interesting for those students, but if they're not at that, they don't have the competencies where they can engage with that effectively, we're just teaching to people who already would do what we want them to do anyway, and not reaching those who don't. And this long-term burden of this mislearning will be carried by young people, the health services, and school pastoral care. One other thing to keep in mind is that this is the first generation who have mass exposure to alcohol and other drug use before learning about it through social media and stuff like that. They see it all around them. So this changes the hierarchy of learning. Helping them to make sense of what they see and hear is now much higher priority than front-loading that knowledge, helping making sure that they have a skill set and a frame to be able to experience and learn from. We need to make sure that they can make sense of what they see and hear, and they can go on Google and hear huge amounts of conflicting information anyway. A couple of examples in the last few minutes before I hand over to the next speaker of what this looks like when the connected approaches are in place. Here's one example of student-driven change. We had students who were involved in creating a wellbeing framework for their school, talking about what they need from school to live healthy and successful lives, the activities that the school can do to help them, and what they want to finish school with. This on one page was used by teachers to reflect and plan their teaching and assessment across all learning areas, and student leaders use that to prioritize their action. Now, there's an 11-week, 400 minutes a week education program for the whole school community, delivered by teachers at that school, led by student voice, contributing to parent events, and finishing with a 4-day story festival where students at that school are able to present what they've learned and get credits in English for that one. Another example of integrated learning for this health and alcohol and other drug context across English, maths, and health was where in English they pick the topic that they want to explore. They go to maths to explore some of the health data and graph it all together. They get top-up education and health, and then they go back to English to present it as a speech. And we found that while teachers were thinking that it was too complex, students were asking and craving more challenges to think critically. And the teachers found that that was some of the most meaningful teaching experience that they had, because later on in the year when they went on the school camps and stuff like that, those students knew that it was okay to talk about well-being issues, and they were bringing their whole self to the conversation, and it was much easier for them to get support. And the last example is one school that focused on creating a student support pathway that students, when they first started at the school, were educated in ways to reflect on their well-being, different health topics that could impact that, and ways to think critically about a situation. And this could be revisited when there were incidents through a support plan that used all of those as learning opportunities. The school also decided to innovate and create harm minimization conversations as a tag in their student management system so that they could have data to keep track of where and the groups of students who would need that conversation. And all of this creates the ability in this ecosystem for innovation to happen at a school, because if we're only relying on experts coming into the community, we're not going to be able to create a system that evolves over time to be what those young people need and to give that context that matches what they have experienced. We had some really good feedback in our evaluation as well that we're really happy to share that highlight some of the systemic factors across a school and those health providers that influence the pace of change, that helped us to be able to map out what we needed to improve, where we could identify things in that system that would mean it was harder to incorporate this, and the strategies that we could use to be able to strengthen that. Thank you very much. Those are my snapshots.
Thank you so much, Ben. Thanks a lot. Actually, it's very beautiful to learn how students are also driving and making changes together with the community, together with the school community. So basically, everybody is integrated and included into the development of the best practices of drug education. Thanks once again, and I would like to present now Dan Werb, who is an addictions epidemiologist and drug policy analyst, also is the director of the Center on Drug Policy Evaluation. Dr. Werb holds dual appointments as an assistant professor in the Division of Infectious Diseases and Global Public Health at the University of California, San Diego, and in the Institute of Health Policy, Management and Evaluation at the University of Toronto. Dr. Werb will present Center on Drug Policy Evaluation's work on primer, preventing injecting by modifying existing responses. It's a multi-country mixed method study that can be framed as evaluating secondary prevention efforts and highlights how harm reduction can achieve objectives related to preventing injection drug use. Dr. Werb, please.
Hi, thank you so much for the kind introduction, and thanks to the other speakers for some really amazing remarks. So I'm going to be focused really today on one specific aspect of prevention, which is preventing injection drug use. And what I think has been reiterated over and over with the speakers today is that for the most part, for the vast majority of people who use drugs, prevention is not necessary. The vast majority of people who use drugs do not require, do not see many harms arising, or if any harms arising from their substance use. And that extends to people who inject drugs as well. So I just want to start by just clarifying that when I'm speaking about preventing injection drug use, it's not to suggest that absolutely everyone needs to stop injecting drugs. And as you'll see from, hopefully learn from the remarks today, that this is not always a realizable goal in the first place, and certainly not always something that we want to be pursuing with respect to public health. So just to note that I have no conflicts to declare, as was mentioned, all of this work is related to the primer study, which is a multi-site study seeking to understand pathways to prevention, or pathways to injection drug use, and how to prevent them. So I just want to start by noting that, despite the fact that there is so much made of injection drug use, so much focus on the harms of injection drug use, there actually is a very small scientific evidence base on approaches that are effective in preventing injection drug use. So that's in preventing people from starting to inject drugs. We conducted a systematic review in 2013 that found that there was just only 8 scientific studies that had ever looked at interventions to prevent injection drug use. And among those 8 studies, it was clear that the vast majority of these evaluations to date have been ineffective. So there's lots of work to be done here, especially given how much of a premium governments and communities place on preventing injection drug use. So despite the small evidence base on what's effective, we do know some key things about how people start to inject drugs. So from the scientific evidence, from cohort studies of people who inject drugs, from cohort studies of street-involved youth, we know that the majority of people who inject report that they were assisted in their initiation by someone else, that other people who inject drugs were present when they initiated injection drug use, and that they were offered injection drug use prior to being initiated, or were exposed to injection drug use practices prior to initiation. And in a subsequent systematic review that we undertook recently, we found that the proportion of people who said that they were assisted in their initial injection drug use ranged from about 88% to 100% of people who injected drugs. So really, this is a pervasive phenomenon whereby people who initiate injection drugs are generally assisted in that initiation by somebody else who injects. So what does that mean? I mean, what's the implication there? The implication is that we know that there are a number of factors that increase the risk that somebody is going to initiate injection drug use. And here I've listed some of them. But we also know that pathways to initiating almost always include somebody being somehow familiar with drug injecting and generally being assisted in their injection initiation event. So what that means is that in isolation, exposure to injection drug use and being assisted is a risk factor, but it's not sufficient on its own. There is this relationship between these factors, which are not on their own going to necessarily lead somebody to inject drugs, and the factor of being exposed to injection drug use. And these in combination are what influence people's pathways into injecting. So to give you a sense of sort of how this phenomenon operates in the real world, there's data suggesting that on average, people who assist others in injection initiation events, so these are people who inject drugs, who assist others in their injection initiation events, report on average assisting about 15 other people across their life. So that means that for every single person who assists others, there's about 15 other people who may be exposed and may be assisted in their injection initiation event. So, and then of course, one of those people could potentially move on and assist others. So what does that mean? Well, that means, and maybe I'll just pause here for a second, that if we want to prevent people from starting to inject drugs, then we should look at what makes people who inject drugs who assist those more likely to do so. So really what we're looking at is drilling down to make prevention efforts as effective as possible, because we know that classical drug prevention, these broad-based social marketing programs are simply not effective. And in some cases, what the US Government Accountability Office found is, in the case of the US's multi-billion-dollar National Youth Anti-Drug Media Campaign, that these could actually be harmful. So we need a different approach. We need to think about, what it is that we're actually looking to prevent. And we need to drill down to those populations that might actually benefit. So understanding the role of people who inject drugs and assisting others, we sought to understand what makes them more likely to assist others into injection drug use. And what we found, in fact, is that classical approaches to preventing drug markets or for policing drug markets and preventing the initiation of injection drug use, which is aligned with this theory of deterrence that was popular in the 1990s and through the 2000s, we found that actually law enforcement interactions with people who inject drugs may increase the risk that they assist others into initiating injection drug use. So this conceit that drug law enforcement is an effective way to prevent new people from starting drugs appears to not actually be correct, and it may in fact be the inverse, where you see that people who have 2 to 5 times, and these are data from Vancouver, Canada, by the way, people who report interacting with law enforcement 2 to 5 times in the past 6 months actually have an increased risk of assisting others. We also found that, you know, and this is important, I think, that people who report that they're likely to assist others into initiating drug injection are vulnerable to infectious disease. So people who had a higher number of syringe risk behaviors, so sharing syringes, distributing syringes, receiving syringes, were reported being more likely to assist others into initiating injection drug use, which again suggests that, you know, there are some public health benefits to focusing on this population and meeting their needs and understanding the risks and vulnerabilities that place them in a position in which they're assisting others. Now, while there isn't a lot of data on what can prevent people who inject drugs from, or prevent people from initiating injection drug use, there's one real world example that I think has been sort of lost in the literature and lost in the conversation, but is quite, I think, impactful. Here is the example of Switzerland. So in 1993, Switzerland scaled up a public health oriented drug policy essentially to address what they saw as an epidemic of public disorder related to injection drug use. So that involved scaling up supervised injection facilities, medication-assisted treatment, needle and syringe programs. And what they found and what happened was, while the proportion of people who were injecting drugs who were injected in public dropped dramatically, the proportion of new injectors also dropped just as dramatically. And that has been sustained over now about 25, almost 30 years. So this shift in the orientation of the drug policy from a law enforcement oriented drug policy to a public health oriented drug policy actually reduced the incidence of new injection drug use initiation. So that is quite remarkable. So we wanted to understand why. And what we did was we looked at specifically at medication-assisted treatment or opioid agonist therapy, essentially methadone, buprenorphine, these kinds of therapies, and found that people who had a lifetime history of enrollment in opioid agonist therapy were 40% or so less likely to assist others into injection drug use. When we looked at current enrollment in opioid agonist therapy, we found that almost 45% of people, there was a 45% reduction in the risk that people who injected drugs assisted others. And when we modeled these, we found that over a 10-year period, we actually, if you scaled coverage of opioid agonist therapy up to 60%, you could see a 25% relative reduction in the incidence of people beginning to inject drugs. And while I don't have a ton of time left here, I just want to note that, you know, what are the implications here? Well, we understand that starting to inject drugs is a rational response for some people to pressures from trauma, poverty, and pain. So the goal of 0 incident cases of injection drug use initiation is not a realistic or worthy public health goal. But we should be tailoring interventions to the population of people who inject drugs who are morally ambivalent about and at high risk of assisting others into injection drug use. And it appears that we can do that by tapping the potential role of opioid agonist therapy in reducing the risk that people who inject drugs will assist others into injection drug use. So that's it. I will stop there with just a few minutes to spare. Thank you very much.
Thank you so much, Dan. And thank you also for all the presenters for sharing your work on the improving prevention efforts globally. And we are actually kind of coming to the end of our assigned event, but we still have one presenter. So I'm very happy that our event was supported also by the Government of Canada. And today we have Representative Bobby Chauhan, who is the manager of the international unit within the Controlled Substances Directorate at Health Canada. He has been involved in the area of drug policy since 2017, and in this role, he's responsible for leading Health Canada international drug policy engagement in collaboration with government and civil society partners. Prior to this, Bobby worked in the area of policy development for biologics and vaccines at Health Canada, where he supported key initiatives, including regulatory capacity building efforts in low and middle income countries. Bobby also held a master's degree in pharmacology and bachelor's degrees in criminology, as well as biochemistry, all from the University of Ottawa. Bobby, could you please make a few remarks to reflect on the panelists' interventions?
Yes, thank you very much. And I know we're short on time, so I'll be quick. I'd just like to thank all three panelists for their excellent presentations, very informative. I have a few notes that I made, and I'll just go quickly over it. And most of it, actually all of it's really in agreement to what we've heard. For Irena, very interesting to hear and see those videos in terms of how drug education nowadays and the focus by a few of the individuals on stigma and how stigma impacts the education, especially in the formal settings where the term lecture is used, and that's kind of like where we're seeing a very traditional approach to prevention, where it's more of a lecture approach that really doesn't connect with youth really. Another thing I was very happy to see is that in terms of the effective video towards the end, how there was a lot of a push for scientific evidence-based prevention services, and that really does align with Health Canada's and the Government of Canada's approach to our drug policy efforts under the the Canadian Drugs and Substances Strategy. For Ben, thank you for that presentation. Very excellent as well. I think the one thing that I really found from it is that, when you were highlighting the fact that there's more information generally available to youth nowadays because of access to social media and the internet. So, traditional sort of youth prevention approaches don't really work, and they don't really apply to the amount of information that's coming in. So I think we as governments need to address our approaches to help make it more sense for them, because they're getting a lot of this information on their own, and we have to be able to kind of balance that information with helping them make just generally good decisions, as you were outlining before. And finally, quickly for Dan, thank you for that information on prevention and injection drug use. I think there is a need to consider different approaches to target certain populations. Definitely also agree with the shift from law enforcement towards a public health approach. And as you know, Dan, for Health Canada, harm reduction is one of our key pillars under our federal strategy, which includes a focus on supervised consumption sites, needle exchange, as well as opioid agonist therapies. So I'll just leave it there, but just again to thank all the panelists for the excellent discussion. Thanks.
Thank you so much, Bobby, for your remarks. And as we are running out of the time, I see that we have one question. So I really would like to address this question maybe to Ben, but also other panelists. Please feel free to share your insights. So how get the students to share how can actually students to share their experiences, how they probably can feel safe while sharing their experiences? It's probably addressed to that student-driven change and how they can suggest to their school society different approaches. So Ben, could you please answer to this question?
Yeah. I think there's a few points around this, that the environment that students experience at school and what they see around them is really important. As an addiction practitioner for several years within schools, if the school purely had a disciplinary approach where students knew that they would go straight for a punitive consequence, they ended up trying to game the system rather than being able to reflect honestly. So anything that a school can do or any environment can do to help them to feel like it's okay to bring their authentic self, that change for the adults in the system can take quite a while. But what we found was that that change for students can be really quick. So in that student-led example that I spoke about, that was the second year that that school had student leadership. The first year, the students did a lot of work around that. The second year, that was just what was expected of the school. The next students who were coming through as student leaders, they didn't realize that that hadn't been there before. And that's how quickly that students can experience change. The last point around that I'd say is take into account the context and make sure that your ask is appropriate for them. So what we were recommending for schools early on was that their ask of students is to think critically about what they see and hear. So they are not necessarily required to share their own personal experiences, but they can choose to. And it wasn't until they got into a supportive approach together with a counselor or a support worker or somebody like that, that they would be asked to bring more of their whole self into the conversation.
Thank you so much, Ben. I hope so that the question is answered and the participants are happy with the answer. Maybe somebody else from the panelists would like to make their final remarks. In case no, then actually I would like to thank you once again, all of you who participated in our side event. And in the end, I would like also to mention that and to refer all of you to the resolution L5. It's a resolution on promoting quality, essential scientific evidence based on comprehensive drug prevention and treatment services. So you will find loads of information and recommendations in that resolution also about and around the prevention and treatment. So once again, thank you all of you for participating, for the great presentations. And I know that the topic itself, prevention, is very broad and probably we could discuss here for an hour, but unfortunately we had only this 50 minutes. So thanks once again and have a nice day and have a nice week full of CND events.